every tooth of the opposite arch will have the same anatomy. But I want to see what I do. It's the only way in which I can work correctly. So I have to do a correct access cavity. Because if I don't do a correct access cavity, I'm not finding the MB2 canal in upper molars. I'm not finding the medial mesial canal in lower molars. So I have to do an access cavity that allows me doing a correct shaping, cleaning, filling. Because if the access cavity is wrong for position, depth, extension, the possibility that I have a success are low, extremely low. And so what are the access cavities that we can do? We can stick to the conventional access cavity. We can try a more conservative approach. We can do a truss access or a ninja access. What's the difference? With a conventional access cavity, I completely deroof the pulp chamber and I can completely see the anatomy. The guidelines say that you have to see all the openings of the root canals without moving your mirror. So you see very well the anatomy. You need a basic education to do this kind of access. But you're removing a lot of dental tissue. And so you're decreasing the fracture strength of your tooth. That means that if you don't do the restoration in the first appointment, you might want to remove the tooth from the occlusion. If you try to save more tooth structure, you can pick the conservative access. Because you still deroof completely the pulp chamber, it requires higher skills. If you use magnifications, better, because in this case, you still can see all the anatomy, but you have to move the mirror. And obviously, you save more tooth structure, so you increase the fracture strength of the tooth. But we want to be extremely skilled, and we want to show the world that we are good at endo, so we can try to make a truss access and preserve the dentin bridge. So we are not going to do completely the pulp chamber. We need magnification, we need high skills, and of course we save tooth structure. But if you want to be extremely like a show-off, you can do this. You take a CBCT, because otherwise you don't know where to do this tiny hole, and then you try to find the root canal by passing through that tiny hole. The problem is that with this, you are not increasing the fracture strength of the tooth, and you are removing more dentin in the roots. So, if I have to give you an advice, don't pick this kind of access. Do the conservative access, that is the right balance between seeing what you're doing and saving tooth structure. How do we do the access? We start with a small cavity done with a diamond-coated burr, and now we take the ultrasonics and we design the limits of the cavity. And since we have to make the cavity serve us, if the anatomy requires us to extend the cavity, we extend the cavity. This is what I advise you to do before doing an access cavity. Take your probe, take your x-ray and measure and see how deep is my cavity. Where is the pulp? 6 millimeters, okay. How long is my burr? 10. I will need 4 millimeters of my burr to stay outside of the tooth, and I'm sure I'm not going to perforate, for example. This is particularly useful when the pulp chamber is contracted, or you have extensive restorations. Measure with a reference point in order for this to help you in finding the root canal openings without wandering around with your burr. And pay attention to the inclination of the tooth, because if your tooth has a crown, maybe the crown has not the same inclination as the root. And so, check your preoperative x-ray in order to be able to make a cavity with the correct inclination. So we have 3 steps to follow: preliminary endodontic access, enlargement, refinement. You've seen diamond-coated burrs for the preliminary access, enlargement with a multiple blade burr with a non-working tip. You put the tip of the burr on the floor or the pulp chamber, and then you go around enlarging. Then ultrasonic tips to refine the cavity, and then you find the orifices. To pass from that to this is 5 minutes, even less. So don't settle for this kind of access, because with this kind of access, if you don't remove these, you're letting inside of the tooth a lot of bacteria. You will not be able to clean correctly. So remove the pulp calculus, the whatever. You have to get this. So what do? I do my radiographic evaluation. In the crown, what do I see? A decay. In the middle third, do I see something strange? No. In the apical third, big lesion. First thing, I do a clinical evaluation. There is a sinus tract. So I can feel immediately the root canals and I will have no problems, even if there is a huge infection. And then I isolate. I remove all the decay, all the restoration, all the unreliable dental tissue, because now I'm already starting to think about what restoration is best for this tooth. And then the map of darker colors on the pulp chamber guides you to find the root canals. You take your working length. This tooth had a large size. I can use the TDG6 because they're like protector gold, so why not? I use them. And this is it. Immediately I restore. 1 week later, the sinus tract is gone. 2 months later, the patient is like this. Do I always have to make a build-up before doing an endodontic treatment? As long as I can put my clamp, no, there is no need. These are the situations in which I do a pre-endodontic build-up, when there is no tooth left, because I also evaluate if the tooth is restorable or not. If the tooth is not restorable, I extract it. If the tooth is restorable, as in this case, I open a flap, I put my matrix, rubber dam, pre-endo build up, and then in a second appointment, I do the endodontic treatment. This is no easy tooth. I need small tapered files because it's long and it's thin. So choose the file according to the clinical situation. And then I fill single cone and gutta percha, the easiest filling technique in the world. Treatment planning. What am I doing? 16 years old patient with a large decay and large periapical lesion. It's impossible to place the rubber dam. So, as we have just seen, crown lengthening, open flap, pre-endo build up, root canal. And then restoration. Always with these very flexible, small tapered files that helping in managing this kind of situation. So, to summarize, if I have an intact tooth, I do a conservative access cavity. But how many intact teeth are we treating endodontically in our practice? Few. Most of the time we treat teeth with restoration, with decays, so we do a caries-driven access. We remove all the restoration, all the decay, and then we do the access. If we cannot isolate, we do a pre-endodontic build-up. And if I do a retreatment, I always modify the access cavity, because 90% of retreatments are linked to the existence of a wrong access cavity that made the treatment fail. This is an example This is a patient who requires a huge rehabilitation because he has lost vertical dimension, he has lost the molars, he's a bruxist, he has clenching, so he needs a big rehabilitation, and a colleague of mine does the rehabilitation. And he decides that he wants to do the endodontic treatment on the two lateral incisors. But he is no endodontist. He takes a panoramic X-ray as a preoperative. And so he doesn't see the anatomy of this teeth. And he tries to find the root canal in one tooth, and he doesn't, so he stops. He tries to find the root canal in the other tooth, and at a certain point the assistant keeps kicking in and says, "Stop, doctor." He stops and sends the patient to me. This is the preoperative that I do. The inclination was completely wrong. I think he perforated there. So I do a CBCT because I don't know what the situation is. Wrong access, nothing, because the tooth is calcified, it's a bruxist. And then the root canal. So I can treat it. I can find the root canal. You see here, this is the most common mistake in doing an access cavity in an incisor. The orientation of the burr is to buccal, and most of the people end up perforating here. So the advice in this case is to always remember which is the anatomy of the teeth, remember the inclination, and isolate multiple teeth in order to have as a reference the nearby teeth. So I correct the access, find the root canal, I do all of my cleaning, shaping, filling, etc. And this is the post-op. And I send the patient back to him for restoration and the crown. And he's still alive. The same on the other side. CBCT, his cavity, my cavity, intra-op and post-op, and the follow-up. This is another problem. Perforations, often due to a wrong access cavity. So, a colleague tried to retreat this tooth, and he didn't find the canals. At a certain point, he found something that was bleeding. So he tried to clean and fill it with a thermofill. The patient was crazy in pain. So my colleague said, "Okay, I'm extracting the tooth." And the patient said, "No, I'm 40. I want my tooth. I don't want an implant." And I agree with the patient. So he sends me, the patient, to try to recover his tooth. I asked him for his preoperative X-ray. You see, there was no perforation. He did it. Why? Because the inclination of his access cavity was wrong. He wasn't able to do this in order to find the opening of the mesial canals, and so he would not retreat them, and he perforated. So I had to remove the thermofill from the perforation, and you have this kind of situation, bleeding, because the periapical tissues are very inflamed. So the only thing I can do in this moment is to seal the perforation with MTA and wait. I wait for a week, and when I see the patient in the second appointment, I control if the MTA is set. If it's set, I do the retreatment and the build-up, and I put a composite overlay because I don't want the patient to spend much money on this tooth. I do the retreatment, 6 months, and 1 year follow-up. I didn't save this tooth for all the life of the patient. I don't know how long it will last. But implants are not forever. So if he gets an implant at 60 instead of at 40, we all are fine with it. Shaping. What are the rules and the objectives? I want something that completely incorporates the original anatomy of the root canal. That means that all the surfaces of the root canal are prepared. But we know that no existing endodontic instrument can touch all the surfaces of the root canal. No existing instrument. And we also want to save as much cervical and radicular dentine as possible. This is called pericervical dentine. You take the bone 4 millimeters up, 4 millimeters down. It's the pericervical dentine. And we don't want to weaken the tooth. We want to prevent fractures. The thickness of the dentine has to be at least 0.3 millimeters. And we have to prepare the canal with a continuous and uniform taper. And we have to allow a sufficient amount of irrigant to go inside the tooth and fight against the bacteria, above all in root treatments. So, the literature says shape the root canal, but there is no agreement on which is the final size of the preparation and which is the final taper of the preparation, because you have to decide it from case to case. Why with rotary files? Because they are faster, more efficient, more predictable. They allow you to have a better irrigation and they respect the root canal anatomy. And they lead to less post-operative pain. Why? Because if we make debris extrude from the apex, we are going to worsen the inflammatory response of the host and cause periradicular inflammation. And the shaping promotes the extrusion of debris, even if we stay within the limits of the root canal. But nitride rotary files bring less debris outside from the apex, because they take them outside from the coronal third of the root canal. And so, they are associated with less apical extrusion, less post-operative pain. Why? Because they were like this. If I have some debris, bacteria, pulp, remnants in the root canal, and my cave file works like this, it's going to push the debris outside from the apical part of the tooth. This way. For their design and for their nature, rotaries go all in the opposite direction. And so we have the debris, and when our file rotates, they come outside from the coronal part. We are afraid of breaking instruments when we use them, above all when we start using them. But you have to know why they break. They break for these reasons. So mainly because we use them in a wrong way. We have to be trained in using rotary files. And we have to remember that we need a glide path. That is a smooth path from the crown to the apex. And we have to do it with a small tapered instrument. Because in this way we are going to optimize the root canal shaping. We will reduce the chance of apical transportation. We will reduce the chance of breaking files. And with rotary files it's so simple because their tip is not active. If I do it with K files that are stiff and with an active cutting tip, I risk to make ledges, blocks. I risk to perforate, go in the wrong direction. And these are all articles that show that rotary files deviate less from the original path of the root canal if compared with manual files. And this is a study by the University of Turin, Professor Elio Berutti, which is an endodontist with I think about 40 years of experience, did the glide path in an S-shaped canal with manual files. Then he picked a student of the 4th year who had never used the rotaries before. He gave him rotary files and the students performed better than him in his first time use, because rotary files are easy to use. And in this way, we preserve the anatomy and we have less post-operative pain. And you find several types of glide path file in the market. They all perform well. Also because you have to remember that even manual files can be broken in the canal. So it's not all about rotaries. The aim of the glide path is to transform this situation into this. Our files have to go inside and follow the path to the apex. How do I do? I'll scout the coronal 2/3 of the canal. If you want to do it with manual files, do it with manual files. If you want to do it with rotary files, do it with rotary files. And then, step by step, I pre-flare. I take the first 5 millimeters of the canal and I remove all the coronal interferences. I pre-enlarge the canal. Then I can go to the working lab with my manual cake files and then I do the glide path. But I know the anatomy of this file. And then I go on, I shape the coronal 2/3, and then I go to the apex and I choose which is the final diameter and taper of the preparation according to the anatomy of the root canal. I do my final rinse, I fill, I restore, and then I follow up. And this is all of the shaping. In this case, sorry, the video didn't go, is no easy case because there is a calcified tooth. So I have to remove the existing restoration, and I find this. And that's a calcified pulp chamber. I can use stains. This is methylene blue to help me finding where the root canal openings are. And then I start from the easiest canal. In lower molars, the distal, because it's large, and go shaping it. And then, which is the second easiest canal in lower molars? The mesiolingual, because it's bigger and straighter than the mesiobuccal. So I start with that. Also because many times in lower molars, the two mesial canals have a confluence. So I want to shape to the apex only one canal and shape the other canal just up to the confluence. And the map on the pulpal chamber floor is guiding me to find where is the root canal opening. And you can see I go straight in with my rotary files because they find the path in an easier way than manual files. Because if I have to push one stiff file into the root canal, I apply force. The tip of the file bends. I create blocks. In this way, it's so easy. I did the coronal pre-flaring. Now what I'm doing, I am taking the working length and I'm doing the glide path. I use a lot ultrasonic tips because there are some areas, like the isthmuses, that files cannot clean. With ultrasonic, you can clean it. So I take the working length and we finish our therapy. Irrigation, activation. I go fast because I think that the time is about to finish. So we do this. This is immediately after the filling and with the omelet. We have to define which is the shape of our canals. Are they wide and easy? I'm using a sequence. Are they regular? I can use another sequence. Are they narrow or difficult? I can use smaller taper files. It's the anatomy of the tooth that guides you to choose which file you are going to use. This case is an easy case. Narrow canals. Open the excess cavity, working length, I finish the shaping, I do the restoration. Immediately post-op, 6 months, 1 year, 2 years, follow-up. The lesion is healed in both teeth. And that anatomy is completely different from this one. Thin, with a confluence, so I'm using different files in this case. And we have to remember that we are fighting against these kind of things, against microorganisms that can hide inside of dentinal tubules. So we need to clean effectively. And this is a nice article. Now I'm going quick because we have few time, but this is going to tell you which irrigant, how to deliver it, and which protocol to follow. Because we are fighting against drug-resistant bacteria in tight spaces. So we have to deliver the irrigant in an efficient way if I want it to work. So the ideal irrigant is this one. And you're gonna see that sodium hypochlorite has many of the features of the ideal irrigant because it's able to dissolve organic tissue, it is antimicrobial, it is low cost, it's fine, but it's not enough. I also need a chelator that is going to disrupt the biofilm and take care of the inorganic components they find into the root canal. So I can use DTA, citric acid, malic acid, you choose, but use a chelator. And don't alternate them. You use sodium hypochlorite first, then you rinse, and then you use DTA. What about chlorhexidine? It is not advised anymore because it has a lack of tissue dissolving ability. It reacts with sodium hypochlorite and creates an orange-brown precipitate that is going to stain the dentine. And so we are not using it anymore. Your final irrigation is EDTA, sterile water. If you want to use sodium hypochlorite again, use it. How to deliver? You have to refresh it frequently because the active part of sodium hypochlorite is undergoing consumption when it reacts with soft tissues, with debris, etc. So, refresh the irrigant and develop a reverse flow, no open-end needles, side vent or double side vented needles in order to prevent sodium hypochlorite accident. And this is the protocols. Once you have finished shaping, you take 10 milliliters of sodium hypochlorite per root canal and you deliver it slowly, drop by drop. And then you rinse with sterile water, 2 milliliters of EDTA. It means that for a molar you spend about 30 minutes cleaning. And this is the minimum, okay? If you want to spend more, spend more. And this is why if I take a short time shaping, I'm happy. And we have to balance all of these. Taper analytical size of the preparation, irrigation, and time that we want to spend irrigating. What about the filling? We have to seal the root canal system three-dimensionally, and we can use several techniques. We can use a wall vertical compaction of the gutta percha. I showed you before, you set your step 4 millimeters short to the working length, and then you have placed into the canal the gutta percha with the sealer, you heat until you reach the position of the stop on your reference point, and then you pack. And then, when you have done the down packing, you will do the back filling with one gutta percha. Why do I stay inside? Because I'm allowing the gutta percha to heat before taking out my lager, and then I pack. But I can also use a single cone technique, a cold technique, with a bioceramic sealer because it is non-resorbable. So I put the bioceramic sealer into the root canal. If you want to reduce the extrusion, you can also put it on your gutta percha point or put it inside with the K5 you choose, and then you insert your gutta percha point and you're finished. Carrier-based technique. I put the sealer inside the canal, and then with my carrier-based system I insert the already heated gutta percha that is going inside the root canal. For MTA, in large foramina, larger than 50 or 60, I cannot manage with gutta percha, I use MTA. And then I have to restore the tooth according to the residual wall number and residual wall thickness, and according to the function of the patient. So, do I have to put a fiber post or not? Take a picture. This is the protocol. We have a few times, so I'm not explaining everything. But what about molars with just one wall? This says no fiber post, but is it always like this? It depends. In incisors, you follow that protocol. In premolars and molars, you have to check the thickness of the remaining wall. If the thickness is inferior to 2.5 millimeters, it's like having no wall. So in this case, yes, I put a post and I cover the cusps in order to prevent fracture. In premolar, as in molars, it's the same. So I only have the access cavity, composite, no problem. Here, what do? I have 2 walls and a half left. So I do the endodontic treatment, I check which is the function and the occlusion of the patient. What do? An indirect restoration without post here and the direct restoration here. The function in these patients, the teeth have a higher risk to fracture than in this patient. So always check also the occlusal part of the patient. And last topic, single or multiple visit. Do I have to place a medication in infected teeth and wait for 3 weeks and then I have to fill again? No. There is no evidence suggesting that there is a higher success rate in 2 visits or in 1 visit. So the literature found out it is more convenient if you can do everything in a single visit. The only thing that could happen is that your patient has a little bit more of postoperative sensitivity. So in this case, I have to do multiple things. In 1 visit, I do the endo of the premolar because it's an emergency appointment. And then in the second visit, I do the direct restoration here, the restoration here, and I do the retreatment on the molar. And I do immediately the build-up and take an impression. And in the last visit, I only have to put the onlay. Thank you very much. If you have any questions.